This is Neil.
Laura. Caroline.
And this is Maritess. Welcome to Med Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med Surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Hello there. In the last episode, you may remember we said our goodbyes to Alyssa. But in this episode, we're really pleased to say hello to two new regular co-hosts who you may have gotten to know over the past few episodes as special co-hosts Laura and Maritess. Welcome officially to the team.
Thank you, Caroline. We're happy to be here.
Yes, definitely. Very excited. Thank you for the warm welcome.
Yes. So for our listeners and for those of you that haven't met you through the previous episodes as special guest co-hosts, tell us a little bit more about yourselves and share your thoughts as you begin this journey as a Med Surg Moment co-host. Maritess, why don't you go first?
Well, it is an honor to be part of this team and just sharing the experiences, sharing stories in the Med Surg community. That's such a big blessing. I would say it's a privilege to be part of this team. I've been a nurse for 18 years, 16 as a medical surgical nurse, 14 as a nurse leader. One of the things that I really love to do is really share stories. And that's why I say that, this is a privilege. It's so important to have a voice. It's so important to share that voice and hopefully to share that light and positivity to everyone. And hopefully that will make a difference to all of us.
And I'm sure you are going to. We're very glad to have you.
Thank you.
Laura.
I remember seeing the call for applicants for the podcast for backup hosts, and I had just celebrated my 50th birthday, and I was ready to go out on a limb and maybe try some new things. So I took a chance and I applied, and I was very, very grateful to be invited on. I enjoyed my few spots as a backup co-host. Alyssa has left some very big shoes to fill, but I'm excited to be here. Once I started teaching, I recognized how important it is to share stories. And I have 15 years worth of stories to share. So I'm excited to see where this goes. But I really, really do appreciate you guys bringing me on and welcoming me to your team.
Well, we are certainly glad to have you.
Well, that's enough about us. What's new with you, Caroline?
Well, it looks like we survived the holidays and everything that goes with it. And so we begin our new year with optimism and resolutions. Again, I've transitioned into a clinical nurse leader role. Certainly haven't forgotten what it's like to be on a floor and supporting nurses at the bedside, but it's certainly amazing to still see it in action with the same commitment and compassion that I always remember. Neil, what's been going on with you?
I've recently tried to get on at my hospital for CBL writers, your computer-based learning classes, trying to get into working with that just to get a little bit more hands-on in the education field and the nursing field. So I'm excited about putting it in. I have to do a couple of workshops before possibly being part of that kind of a committee. So hopefully that will come to fruition.
Sounds like a great opportunity, despite all the negatives that went with COVID. Certainly computer-based learning is on the up and up for sure. So that sounds really interesting. Good luck with that.
Thank you.
Well, let's move on to our topic for this episode, how to deal with ethical dilemmas. This is one of my topics that I suggested. So I thought I'd start with why I chose the topic, and it really connects to the fact that I am back in a clinical setting and seeing all sorts of ethical dilemmas every single day. And some are maybe not ethical dilemmas, but they're just everyday decisions. What do we need to put in place to get this patient discharged? And what happens if we don't have that? But then we certainly have a lot of very complex medical, surgical, orthopedic patients on my unit. And some of them come with some pretty heart-wrenching family histories and situations where you think, what would I do? And isn't that what an ethical dilemma is all about? Ethical or moral dilemma when there's a problem with decision-making. And of course, as is the way in hospitals and multidisciplinary teams, there are a lot of people with a lot of thoughts and opinions about things. But the bottom line is we have to come up with a solution that's absolutely acceptable from an ethical perspective. I'm going to kick off with a story that is kind of happening right now on the floor that I'm working. A little lady was admitted from a nursing home, having ground level fall and broken her femur. That was the easy part, in as much as we were able to obtain consent from a family member over the phone, take the patient to surgery, fix the leg, get her recovered and in rehab. And then it was time to return to the nursing home. And the family basically have abandoned their loved one. The family have said, please don't call us. We won't be making any decisions on behalf of our mother. You have her now, you figure it out. And so the hospital is in the process of getting guardianship for this patient because she has no one to advocate for her. So she's just here with us. Last week, she had a medical emergency and we had to call a code blue. We had to administer full CPR. She survived the episode, but we basically had this little lady with no one and nowhere to go. Should we have pulled out all the stops to run the code? We had to because she wasn't a DNR. Who can make the DNR? The family, who don't want anything to do with this lady. And so, what a dilemma.
Well, Caroline, first of all, that's a really sad story. That's so sad to hear family abandoning, but looking at the other side too, there must be a reason behind, you know? And so that's why it becomes a real dilemma.
Right. That was my first dilemma. There's got to be a history. And the patient, of course, has some confusion. She can't tell us anything. We'll never know, of course. So dilemma number one, what's the history? We don't know. We're never going to know.
Exactly. And the fact that, do you want to dig in? Do you want to really hear from the family member what the dilemma is? Because that probably is a family business. You know, you don't want to be involved with that. In my opinion, I think based on my experiences, whenever I'm dealing with an ethical dilemma, it always boils down to two things: core value and the code of ethics for nurses. What is my core value? Is this something that I would do for my family member? Is this something that I can really perform? I can really implement for myself and for my family members? And then with that core value, we need to be guided with the code of ethics for nurses. So easy to memorize, so easy to remember. We started with 5, I think, code of ethics, and then it became 7, it became 9. There's a lot of them. But how do we really apply them? Looking at the resources too that we have as nurses, I wanted to start with the first one, the accountability, because part of the code of ethics is being accountable for what we do as nurses. Are we competent enough? And so your question in mind that, okay, how do I take care of these ethical dilemma? You're being very accountable. You are practicing how to be an ethical nurse. It's hard. It's very difficult. And this is why I think it's so important that in the facility or in your hospital, connect with your ethical team. There's so many names that it is used in the hospital, but being connected with that team and finding that you're not alone. You're not just doing this because you're following your core values and the code of ethics, but also what is really best for everyone, involving family members too. So important.
You know, Maritess, you bring up a good point. I always tend to think of like, what would I want from my family member? What would be the true compassionate thing to do? And then I always think about, what am I able to do and not have a sleepless night over that decision? Too many times we've seen plenty of geriatric age type situations like this, that there's got to be a history that the family's dealing with them, but it's your parent. And I've never understood, no matter what situation, and just to abandon them. I can't imagine the patient's feeling, whether they have some touch of dementia so they know it or not. it happens way too often, and the hospital has to get state of the ward, and then it becomes a placement issue too.
Neil, you mentioned geriatric patients, and I know that does happen a lot, but it also happens to indigent patients and patients who don't have insurance and patients who are homeless. When we've treated what they came into the hospital for, sending them back to their prior location sometimes is really, really difficult to do when you're talking to them and you're getting to know them. Their situations are hard. It was really, really hard to discharge a homeless person when you know they don't have a home to go to. Sometimes there's not a good answer. There's not a good option for them sometimes.
Yeah. Whether you're talking about long-term wound care, follow-up long-term antibiotics from a foot infection because they're out walking the street all the time with no shoes. I mean, what do you do?
Right. It's not going to heal.
Yeah.
So there's a school of thought that says, do we want to use resources on this patient when in the end, it's not going to make that much of a difference? That's a dilemma.
I remember one story, and this is really sad because I got in trouble for not discharging a homeless person during a rainy night here in Florida. 12 midnight, we need to discharge our patient. But really, am I really going to discharge this patient at 12 midnight? I told my charge nurse, you can write me up. I am not discharging. She really wrote me up. That's what really happened. And I said, I can't. I just can't do it. So basically, I got in trouble. I had to go to HR and explain my side. And I was told, follow your policy. And I said, well, then maybe we need to plan better. We need to make sure that things are followed up, done well before midnight so that we can discharge a patient. Things like this, how can you deal with it?
I'm so sorry. Yes, it's hard. It's hard. I've had to make decisions like that too, even as a manager. You feel for these patients when they stay with you for a long time. That really plays into that dilemma. In my heart, this patient does not belong out there on the street, but their personal situation is that they live on the street. There's not a good answer there. Going back to what you were asking about, Caroline, about how do you make that decision? I don't think there's a great way to make that decision. You have to use the resources that you have. So you talk to your charge nurse, you talk to your social worker, you work with the physician. If there's an ethics committee in your hospital, maybe bring them on board. But ultimately, sometimes there's not a good answer.
The difficulty arises when we know that no matter what choice we make, there's going to be consequences. I'm glad that Maritess mentioned our code of ethics. And I'm glad that you, Laura, just mentioned an ethics council coming together around a table to talk about it. At the end of the day, there's always someone going to come away thinking that the right thing didn't happen. As nurses, we're problem solvers, and we're used to being able to fix that problem. And this has always been very conflicting for me because I need an answer. And sometimes you have to walk away from these meetings and just understand that there isn't a good answer. We just have to go with the best answer.
And thank you, Maritess, for being a patient advocate still. It's so hard, as I think sometimes as we get older, to not kind of become jaded about everything and that you still have your heart in it like a young nurse. You know, I think when you're young in nursing, you're like so like pro-patient. And sometimes when you go through those examples of standing up and it doesn't go the right way, like you said, Caroline, like, you know, you don't get the outcome that you want. You kind of become that defeated attitude, that learned helplessness. So I'm glad that even in your time in that you're still like, hey, we don't need to put him out in the thunderstorm just because he's homeless. We could wait till tomorrow morning. The census is done. It's midnight, you know, the infamous census. I'll be honest. I would try to give him a few extra blankets, supplies, or whatever it is that's not going to really dent anything for us. And it's interesting when you talk to some indigenous people with some of those ethical issues like that. And it's literally a choice. This one guy had a very Hakuna Matata attitude about being indigenous, where he just chose not to have the responsibility of a mortgage, not to have the responsibility of a house payment and a car payment and bills and stuff. His worry every couple hours is what I was going to eat.
Yeah, and I mean, you talk about new nurses, Neil. For those of us with some years under our belt, it doesn't really get any easier and can make it even harder to advocate for a patient when you've got a new nurse saying, well, in school they told us we have to do this, 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 and this. Then it becomes even more of a challenge because these dilemmas come in various forms and different reasons along the way. And so the hardest thing is to figure out, how it makes us feel or what we think about this, and then how to come up with an objective solution as possible.
Yeah, trying to be okay with the answer that you chose, even though you're not 100% sure it's the right one.
What if the dilemma is really nurse to nurse in nature? You're trying to advocate for your patient, and then your colleague would say, nope, this is really not what's happening. Or I'll give an example. What if you see a colleague that's not doing the right thing? How do you solve that problem? We also need to be in a professional organization, just like AMSN, because learning about the conscious bias, learning about the policies, standards of practice, and this would really help guide us, even though there's no correct answer in every care that we do.
We always feel like we have to come up with an answer. And I think at the end of the day, we have to walk away kind of no harm, no foul. This is what you think. This is what I think. This is what someone else thinks. What's the best solution in the interests of the patient? And as you just said there, maintaining your professional, legal, ethical obligations to your patient by first doing no harm, going right back to that Hippocratic oath.
Actually, a somewhat similar situation. I was on the psych unit and they had a patient out on the GI floor and they thought she had a GI bleed. And she was already on the list for the state hospital for mental health. And she started having behavior then there. And so they weren't too sure if it was blood loss or psych. And with her being on the state hospital list, she's not competent enough to sign herself into psych. And they were trying to bypass the system and say, hey, she could sign in. I'm like, she's on a waiting list for a state hospital. She can't really sign herself in. She's mentally incompetent. And so it became a real power struggle with this doctor from the Med Surg floor and kind of schooling him on the psych aspect of it. And that's where ethics came in and they really got a true psych eval on her and realized once they got her hemoglobin stable, once they got all of that, they were able to involuntarily commit her back again, which is the right thing to do as opposed to try to bypass the system. But it's always a challenge, whether it's Med Surg or psych, to know what's the right thing to do about a patient. We're dealing with another issue right now where we had a patient who had overdosed on insulin and had a anoxic brain incident. And now she's somewhat a vegetable, I hate to say that term, feeding tube, very liable behavior. Now ex-husband has washed his hands of her. And so now she's fallen onto the hospital's hands of where are we going to get her placed. So these are always problems that pop up.
Yeah, we could probably do an entire podcast on placement of some of these patients, because that's always a challenge. Another ethical dilemma that I have dealt with is the end of life. When you have patients that have expressed wishes, but maybe they didn't write anything down, or maybe they didn't have anything prepared, and all of a sudden they're unable to make decisions for themselves. So it falls to the family members. And sometimes family members don't always agree. So we have had many family meetings where there were knockdown, drag out fights because there was no directives from the patient.
Right.
And the next of kin could not agree on what direction to take.
On the upside of that, Laura, you make me think of a situation that happened not too long ago on our unit. A patient had been up and ambulatory and living in an independent living facility. Took a tumble, hit the back of her head, developed a subdural hematoma, and became increasingly confused and unresponsive. The family knew immediately what was going to happen, and that was to withdraw all care and to start a morphine infusion and to say their goodbyes to the patient. The way that they did this in such a systematic, pragmatic fashion to some of us was like, oh my gosh, this is so quick. A week ago, this lady was up around and walking and talking. But as we were getting to know the family in the very short space of time that we were looking after this lady, they said that they had gone through the same situation 4 years prior with their father, and it wasn't as decisive, and they just sat and watched him suffer. And this way, they said, Mom was very intentional in saying, do not let this happen to me. When I reach this moment when I cannot make decisions for myself, do whatever you need to do to facilitate my departure from this world so I can be with your father again. And so it was a very matter-of-fact decision, but yet a very spiritual decision as well, in that she knew exactly what was going to happen and where she was going to go, and she was at peace with that. And so within the space of about 36 hours, we saw this patient pass away, and the family were at such peace with it.
That was a gift that she gave her family, making those decisions ahead of time.
Isn't it, though? And there was so much less dread and dilemma about what to do. They were very definitive. This was the conversation. This is what's going to happen. If you can assure me that there's no way she's going to recover from this, then we know exactly what the next step is. And it was a very beautiful thing to see. It really was. It really was. So I think it's very important for us to make our needs known, to make our patients' needs known, so that we can follow through and minimize any further suffering that goes along with that. I think that's one of the biggest dilemmas we see in healthcare all the time.
I think as nurses, we're horrible. I know I don't have my DNR last wishes done. So the day comes, I think that's important to we kind of glaze over that question when we do admissions. Like, oh, do you have any DNRs? It's up. No, we'll take care of that afterwards. And that could change up in a moment.
And that is what I wanted to say a while back, because in orientation, the first question I ask when it comes to the topic of wills, last will, testaments, and all those, I ask, who among you have prepared your will? And nobody would even raise their hand. I think we're giving a very good point here. As nurses, we have ethical dilemma, but at the end of the day, it's really about the patient. So it's really a collaboration now between what we feel and think, but also what the family patient feels and think. And that is where we can really come up with a good decision. Sometimes we say this is hard. This is really a bad situation for this patient, but because we are naturally very compassionate as nurses, we are caring and compassionate, and we are here to care for our patient. But if our patients are really decisive of what they wanted to do, family members being very decisive of what they want to do for their family member, it makes easy for us. And so it's really that collaboration, I think, that we really need to foster in our culture when caring for our patients.
I think the other thing to consider is the ethical burden that comes along with an ethical dilemma. It's very common for patients or their families to ask us as nurses, well, what would you do? What do you think? What would you do for your parents? And then you have to be very careful crossing that professional line, because you never want to be in a situation where they say, well, we did this because you said to do this. You did this for your mother or father or whoever. So it really tests us from the professional perspective to be ethical ourselves as well, because people trust us. People look to us to have the right answers because we know best because we're nurses. But sometimes we're just the same as everybody else. It's very hard to make those decisions for the good of the patient. And when emotion gets involved, it makes it even harder.
You can't predict how things are going to go, because you could have two patients side by side look exactly the same. They will react completely different. You just don't know.
Exactly.
I think we definitely need to kind of reach out to these new nurses and just let them know that we have to stick to the facts. We have to stick to what we know. We're not here to make any decisions for anybody. All we can do is help them make the best decision that they can. Make sure they have all of the facts.
There was a family member that had their dad committed because he was like 95. His wife had passed away 15 years ago. He was in a nursing home, and he kind of made the blanket statement, I'm ready to meet my maker kind of a statement, not I'm suicidal. At the nursing home, they said he was suicidal. And so there's that dilemma. It's like, hey, if I'm a certain age and I've achieved all I wanted to achieve, and I'm a DNR, there's nothing wrong with that. If you just make a blanket statement, I don't want to live, you're not saying I want to die. He says, I'm not suicidal. And in talking to him in a sense, and I could see what he was talking about. He's like, I don't have much to live for. They put me in a nursing home. They don't even visit me. So what is there to live for? There's nothing he's doing wrong. He's stating his obvious facts. He made peace with his maker, and he's happy with his life that he's lived.
It's one of these things that we'll never walk away from as long as we are nurses, and regardless of our role, we come up with ethical dilemmas all the time.
Caroline, I wanted to share something that probably would work because it worked for me. When I was starting as a new nurse, I do a lot of journaling, daily journals. And whenever I have a patient who is really having a bad situation, I'm that kind of person, kind of look back. Is there something that I did, something that I forgot doing, or, conscious, unconsciously, and then write all these experiences. And I still have that journal with me. I share that with my preceptor group. I share that with the new nurses when I'm mentoring them. And I share with them, at the end of the day, you know that you've done a great job. You did what you have to do. At that moment, it may not be the perfect answer. It may not be the perfect action, but you have to understand that you are enough. You've done a great job. And if it didn't go well, it's beyond your control. So don't punish yourself. I think journaling really helps a lot. And I hope those who are listening to us, if you don't have one, maybe start one.
Believe it or not, we're out of time once again. But before we go, let's summarize what we've learned. Be careful, first of all, about getting involved with difficult patient-family issues. It comes down to being as objective as you possibly can, using our core nursing values and code of ethics. I think it's very important that you reach out and find out who your ethics committee is that focuses on this. They're the experts. They've seen this many, many times, and they have some wonderful objective insight, and they can help certainly determine what's best for everyone. It never hurts to think about what you would do for a family member. Sometimes there simply isn't a good answer, but you have to come up with the best answer. We're all humans, and conscious bias, no matter how objective we try and be, is always going to come into play here. Take this as a teachable moment. Learn from your patient's end-of-life ethical dilemmas in your own life, and make your needs known while you certainly can. Very important to be careful when a patient's family asks us for advice. It's wonderful that they trust us and look to us as a resource, but you would never want to be a source of blame. And then finally, as Maritess just said, daily journaling is a really powerful tool that can help work your way through difficult situations and look back and reflect on everything that has gone before.
As we close, Laura and Maritess, we know our audience join us and welcome you to the show. We look forward to the many conversations ahead.
Thank you, Neil.
Thank you. I will look forward to future episodes.
We look forward to connecting with you on the next episode of Med Surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official Med Surg Moments email address, amsnpod@amsn.org. That's amsnpod@amsn.org. I'd also like to remind you to become a member of AMSN or renew your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the Med Surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend Med Surg Moments wherever you get your podcast to help us reach even more listeners.
I invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages. And don't forget to add hashtag MedSurgMoments to your posts.
The content within the Med Surg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, always remember, Med Surg Moments is a moment in our lives, a moment in our Med Surg careers that makes a huge difference.